All right. All right, so I have no idea where we stopped. I truly don't, and I apologize, but I know somebody's going to help me out here. Where did we stop?
We stopped.
Botulism, rabies. So we're in chapter 18. I'm so happy. So we're in chapter 18, and you stopped with what?
Botulism, rabies, and prions.
A few. Like the last chapter is really environmental, but we did to 18?
I don't think so. I don't think so.
Oh, so I finished 17 is what we're saying. Okay, so that's so awesome. Okay. All right, so you guys have done a great job so far. You really, I mean, I know everybody has. What this should all just be doing these last times is that you all are just becoming very familiar with these microbes. Yeah.
But you do things where I think it was like the center of the on rashes do like boards.
Oh yeah. Okay, no, I'm just kidding. But anyway, look, you know, things can be taken out of context. So I think, you know what's come out of it? Like, we look for good that comes out of the crazy, right? But what's really come out of it is how much our nurses are appreciated. You know, it's the most respected profession. The most respected. And medical professions are the most respected by far and away. So you know, what's really good that's come out of that is just that people appreciating the medical community. So because kind of people have united behind the medical community. I would like to say something though, since you brought it up. I would like to say that she prefaced, I don't know if any of you all listened to the entire thing. Did you listen to what she said, or did? Okay, so if you actually listen to what she said on the floor of the Senate, she was talking about she was from a very rural area that made me sort of think of like Wayland and some of these little places around here, the skilled care facilities, but even more rural. She's from an area where there's sometimes only like 5 to 10 people in their skilled care facility, and these patients really need this skilled care facility. But if some of the mandates that are put on their facilities are the same that are put on large facilities, their skilled care places are going to shut down. They're going to lose them. If some of these same mandates that include some of the practices that she was talking about. Now, why she went on to say that about the cards and the nursing, I have no idea, except that maybe in that little, because she started it by saying, this is not for most clinical places. This is not how, but she started it with that. And then she said, so do you get what I'm saying? Everything can be cherry picked to piss somebody off, you know? Did I say that on the recording? But anyway, I have, she just never said what she said. But, you know, if we kind of understand, put that in what she was actually talking about with her facilities. And if you listen to that entire thing, I'm sure she's come out and apologized. She actually said, though, she did lead in, when she was leading in, she said, I'm not talking about that. She said, I'm talking about very rural, very small, that are going to shut down because of this. And then those nurses won't have a job that are there. Yeah.
So we heard on the radio there were several cases of measles broke out in New York last week, and it's already surpassed in 2014. It had it.
Yeah, that had the.
So far since January, it's surpassed.
And we're just in April.
And it's mostly in New York. 70 cases just in New York.
Of that last week, but yeah, it's in like 20-some states, though, right? So I know it's just something to people.
New York is the one that had the mandatory vaccination. You couldn't leave your house.
Well, that's why, because they knew this was going to happen. They knew that this was going to happen, and even trying to do something like that mandatory was still going to be a window of period of time with the incubation being what it is, you know. So yeah, I don't know what the answer is. That's going to be. It's going to be education, right? Is that the answer, guys? That y'all are all part of. That y'all are all going to help people to understand and not be afraid. People are afraid. Those people who are not getting immunized are not doing it to upset the rest of the country. They have reasons that are based from fear, and so you know, we got to have some understanding about that and try to help people get over that and understand, you know, the importance of doing it and how it can be protected and whatnot. There are risks to immunizations.
And they said it was mostly in the Jewish and what was the other one? It was like Jewish and some other type of religion.
Okay, so, you know, and so here's what I'd like to say too about, it's in the, many of these are because of the higher socioeconomic things that aren't religious based. So sometimes when we get news, make sure we're getting it, you know, definitely from good sources, but also that we're hearing the important things about the news, and not articles that are trying to divide you and push you further apart. You know what I'm saying? So listen to the whole thing that somebody says before you try to get angry. You know, right, Molly? You know, Molly, as we bring that up, I wonder how many people really did go and listen to her entire speech, because I don't think they would have been quite as angry, you know what I mean, if they'd heard the whole speech. But I think sometimes when you're just hearing parts, you can really, it can cause us, it can divide us.
She got everything that she said, but she didn't know what she was saying because she was tired.
Yeah, I would have pled like drunk or something. I would have said, listen, I'd had too many martinis at lunch. It was just, I don't even know who was talking. So I said something. I don't know what I said. Oh gosh, I know she's sorry she did that. All right, so let's go ahead, guys, and we're going to keep talking. This is really just what you all are doing, but you've had case studies that you did, but we're just kind of talking about the same thing. So cardiovascular, I moved this little diagram, which I think is great because it's usually at the end of your chapters, if you'll notice. But it kind of just tells you what's coming here in this chapter. It's going to be the different areas like the heart, the vascular system. So looking at some of these, and then the pathogens that are associated. So let's just go ahead and go down. We understand the cardiovascular system and what it's doing. Our cells are mostly stationary, so they depend on this liquid tissue we call blood, delivering all the nutrients that we need and picking up waste and helping to get rid of it, right? So it's dependent on that, but it includes the heart, it includes the blood vessels, the arteries and the veins, and then it also includes the lymphatic system as far as lymphatic return. And what is lymph again? Tell me. What's lymph? It's that extracellular fluid that's bathing our system, that's bathing our cells. Hey, forget I can use this. It's bathing our, and I think I can use it better because it won't fit. It's bathing our cells and then returning that to the bloodstream after it's been cleaned. That's exactly right. And I'm going to get in your way if I do this, though, if I move out.
Okay.
I'm going to be in Jenna's way, but she's not here. All right. So guys, when we think about like the heart, we know the different areas of the heart, the chambers, the upper chambers are atria, the lower are ventricles, but we said we know we have these valves. What is the function of a heart valve? It's exactly right. Preventing blood from backflowing, keeping it going in this closed circular system. So we will look at some things that actually attack the valves. So we can know the basic anatomy of the cardiovascular system. We know the basic anatomy of the lymphatic system. And then we also know about the specialized cells in blood that are going to be protected. The predominant blood cell is what? What is the predominant blood cell? Red blood cell. Well, it's red blood cells, or the predominant cell is red blood cells, but red blood cells carry oxygen. So are they antimicrobial and even of themselves? They actually are, because they carry oxygen, anaerobes wouldn't like them very much, right? So as long as you're getting good blood supply, that discourages anaerobic growth. But then we also have, we also have white cells, exactly. We have white cells like neutrophils and lymphocytes and monocytes. So we know these cells are going to be protected. If you've ever heard the suffix emia, y'all know that means bloodstream. So we've already talked about viremia, fungemia, bacteremia. These are just going to mean the presence of these things in blood. Does it mean that they're actively growing though? Not necessarily. That's going to be septicemia or sepsis. That's bacteria growing, which can lead to septic shock, which is a dangerous drop in blood pressure. And if blood pressure drops dangerously, the heart can get a signal to just do what? Stop. That's exactly right. So when we think about normal biota or the microbiome of these areas, we think of them as being sterile, don't we? We think about bloodstream, the blood is being sterile. We think about lymph as being sterile. But we do know that sometimes things can move this way, and they shouldn't stay in there long. So we really do think about them as being sterile. Let's first talk about malaria. I think most of you all know mal means bad areas, referring to air. That's just what that parts of those words mean. This threatens 40% of the world's population. I think sometimes if it's not happening in the United States, we don't care. But, oh, that's not really true, is it? Oh, well, sometimes if things aren't happening in your backyard, you kind of think, okay, well, that's not my problem. But this really is, and you know, it is a terrible disease. It is a protozoal disease that's caused from a protozoa from the genus Plasmodium, and we know that some of these species can actually have very significant mortality rates. So you can look at this 10-day incubation period. The different species have different prognosis. So depending on which Plasmodium is causing the malaria, there will be different prognosis. That's just kind of FYI. But we do know it has a significant mortality rate. You can see where some will actually cerebral malaria is the most serious complication of that falciparum. And falciparum has the highest mortality rate of those. And again, it's the children that we see most affected in that acute phase. So when we are looking at malarial death rates, and I'm just going to kind of go through these because I'll go back to that one in a second. But when you look, it is actually up more than 1 million each year, and it can be as high as 2 million dying annually. That's just outrageous, isn't it? When you think about that, what is going on with that? I was just going to quickly show you this. You certainly are not going to be responsible for the life cycle of these Plasmodium, but it is a life cycle that requires both the Anopheles mosquito and humans. So the sexual division is actually happening in the mosquito. The asexual part of the life cycle is happening in humans. So the liver is definitely involved, and then these red blood cells is where they carry out part of their life cycle process. So as this is happening and the cycle is continuing, the red blood cells will be lysing in the bloodstream. And what does lysing mean? So damage to this is causing anemia, severe anemia. And you can just, if you want to, look at a few more of those statistics if you want to. Looking at the map of where we see this, you can see in those yellow regions where it is just across the globe, isn't it? 40% of human populations. And again, I think I've mentioned to you all that we've even had malarial outbreaks in the United States, haven't we? And with temperatures changing and warming happening, and we're seeing now endemic species of some of these mosquitoes that we hadn't seen before in these particular areas, we can expect to see more of that. We've already talked a lot about HIV. We know what it stands for. What does it stand for? Human immunodeficiency virus. We know that just because you are positive for the virus, does it mean you have AIDS? No, it does not, does it? It may lead to it, and we'll hope to prevent that by treating it, but no, it doesn't mean you have AIDS just because you're HIV positive. Yes?
What other diseases could mosquitoes get in?
Oh my gosh, like the West Nile, all those, you know, like West Nile and a lot of those arthropod-borne viruses. So we'll talk about a couple of others, but you know, when you start studying in science and whatever, you realize, okay, every life organism is interconnected. We're all dependent on each other. But I remember thinking, okay, what does a mosquito do for us, right? Or what do ticks? Because it seems like they cause a lot more problems than they do not, you know, as far as if you just think, okay, why are they here? Could we just do without them? But then there's some mammals that actually up the food chain are dependent on that. Yes.
So the tick causes the disease when you can't eat red meat, right?
Yeah, the alpha-gal syndrome. is thought to be caused from that. But
Like, is it bacterial, viral, or?
I think it's like your own body's response to it. So it's like we said that not all diseases are actually caused from actually being exposed to something. Sometimes it's what? Your body's reaction to it that ends up being such an overreaction that's what's causing the problem. But let's get back just for this for just a second. I forgot what I was going to say about so HIV, right? And this chart I think is just worth a second to look at just because of the testing for this particular virus. When you look at this, you can see in the early, I don't know if y'all can see this, but it's in your textbook. It's in here. Oh, there it is. I do have a little light where I did for a second. Then it went away.
I just seen it on the wall.
Oh, but how come it won't show on the smart board? Well, that's just like a waste.
It's showing.
It's on the smart board?
What? I don't see it. What are y'all seeing?
Okay, y'all are just trying to freak me out. What are you talking about?
It's
It's up there. It's up there, but I can't get it on the board.
Where?
It's right there. It's right there.
No,
It's right there.
No.
No, we cannot see it.
Y'all are joking. Don't even play.
It's right there.
See it.
Oh, wait, you see it now.
Oh, now we see it.
Now I don't see it. Do y'all see it?
Now I don't see it. I can see it. It's right there.
Now I see it.
Okay, I can see it now. But you know, if I'm to the side, you guys, we couldn't see it. Y'all just we couldn't see it. Some people would make it up, but we couldn't see it. Okay, so now I can't read it. So now I can see the light, but I can't read what I was saying. Okay, so whatever, I'm coming up here. It's like a comedy. All right. This is worth looking at because if you look at the infection, so day one, the infection, so being exposed to this particular virus, when you see this very early on, the antigen will be there. So you'll have the antigen count going up, but it takes a while for the antibody, doesn't it? So it takes a while for antibody response. And doesn't it make sense that as the antibody response goes up, what happens to the antigen load? It's starting to go down, isn't it? When we look at our CD4 cells, do y'all remember the CD4 cells?
Yes.
Yeah. What were they also called? Helper T cells, those helper T cells. Those counts should be up high, but as they start to go down, then we know that usually opportunistic infections are going up, and this is when you're said to be in like full-blown AIDS, right? The thing I just wanted to bring to your attention is this. When you first get exposed to this virus, I'm not even try the arrow, it's not working. But when you first get exposed, you will have like flu-like symptoms. And a lot of you all today talked about illnesses that gave you flu-like symptoms, right? So that's very kind of hard to diagnose something because a lot of things give you those. But then you may miss that particular stage. But then after a while, then what can happen is you have other symptoms that are going along with it. And the AIDS defining illnesses, which we're going to see on the next day, the next little phase is or table is going to be some of these. I've got to get close because I can't read. But anyway, unless I'm closer, I can't see it. So we had talked about Streptococcus neoformans, hadn't I? That was a fungi that can cause central nervous system inflammation. And we do not see that except for in immunocompromised patients, especially AIDS patients. But there's some other things in here that you might look at and think, wait a minute, just because you have this doesn't mean you have AIDS. And that's true. But these people are so immunocompromised, you end up seeing them causing more serious diseases. So, so you can take a look at some of these, and one or two of these would mean that you need to be worrying that this person may be HIV positive or is going into full-blown AIDS. But when you start to see a trend, then this definitely is, these are the AIDS-defining illnesses. I think that we had talked about a ton of these. We know about, do y'all know what Kaposi Sarcoma is? Who doesn't? Okay, so Kaposi Sarcoma is a type of cancer of the underlying lymph tissue. and skin. And so what you'll start to see are these marks that almost look purple black lesions. They're lesions under the skin. I've seen them a lot on the neck. It seems like neck and appendages. You'll see these, but this is only seen in very immunocompromised patients. So AIDS patients, now they are in AIDS if they have Kaposi sarcoma. And there actually is a group of people who are also sort of at risk for this, which is, whatever, but it's mostly that you're just going to see in AIDS patients. So Kaposi sarcoma. Sometimes that's how people find out that they have HIV, is that they've had it long enough that they have already gone into AIDS and they have Kaposi sarcoma. So transmission, we said this isn't something that's going to be really easily transmitted, is it? This is not going to be aerosolized, is it? And it's not even something you can get from saliva, but you can definitely get it from blood products. You can get it from sexual intercourse. You can get it from breastfeeding. Babies can get it from breastfeeding. So it's really important that people know their status for this particular virus. I think I went through this without showing you the slide. I tried to highlight it. But it is recommended that if people have had a risk behavior that may have exposed them to this virus and they get tested early, that they still should be retested in 3 to 6 months after potential exposure. And they should treat themselves as though they potentially are positive, and certainly will try to avoid spreading the disease until they had a confirmed testing to make sure that they had not contracted this particular virus. So I've talked about most of this. I'm going to move on. Do y'all have here's some of the highlighted things for you guys to see. So in the 80s, more than 30 million people had died worldwide. So anyway, you can look at some of these. The number of new infections are still growing faster than the access to drugs, and so that's kind of an issue and a problem, isn't it? Something to be thinking about. I highlighted this because of thinking of HIV positive women who may decide to have a child, their own biological child, and if they are being treated, it reduces the transmission rate to around 1%, where if they're untreated, that transmission rate is 33%, significant. So being treated is really helpful, right? If someone's deciding to have a biological child. So again, just to be sure that you understand, HIV positive status does not mean somebody is in AIDS. There is something called ARC, which is AIDS-related complex, which is just what you're starting to see prior to someone going into full-blown AIDS. You're starting to see their T4 counts, their CD4 counts going down, and beginning to see potentially some of these opportunistic diseases. And then, then they go into full-blown. I had gotten to those. All right. Endocarditis. If we remember the heart's outer layer is the epicardium. The heart's in a sac called the pericardium. The heart's outer layer is the epicardium. The muscle layer of the heart is the myocardium. And the layer that's lining the chambers of the heart is the endocardium. Everybody cool with that? So endocarditis, when we think about endocarditis, this is inflammation of that lining of those chambers of the heart. You can have two variations, acute or subacute. And do y'all know what those two terms mean? You do, don't you? What's acute mean? All of a sudden, and usually symptoms and signs and symptoms are what? Serious, right? Pretty serious. Or subacute, they can be kind of underlying. You're just, not having full-blown symptoms. So there's different types. These signs and symptoms, when we think about it, are going to be fatigue, fever, sometimes joint pain, edema can happen. So these are just some of those symptoms that can actually happen. Petechial rash, do you know what that means? Petechial rash? Petechia or what?
Oh, they're just little bruises, right?
Yeah, they're just like little tiny pinpoint bruises under the skin, and they can be kind of diffuse, almost looking like freckles, except the person didn't have freckles, right? So anyway, that's what it can kind of look like. So there's also, I'm not going to ask you about these, but just so you will say in your back of your brain, you've heard these Janeway lesions or red painless skin spots on the palms and soles. If there's ever spotting on the palms and the soles of your feet, because this is where we have that extra layer, that lucidum layer, remember? If there's ever any kind of spotting or rashes there, then somebody needs to probably go check that out. Because usually when that happens, not always, but usually when that happens, then it's something a little bit more serious, or something that you really want to get to the bottom of, right? So anyway, Osler's nodes are going to be these little nodes that are in the pads of the fingers and toes. In very subacute cases where you've had it for a long time, so you've kind of been oxygen starved for a long time, this is with any chronic respiratory disease too, not just this vascular endocarditis symptom. You can have what's called clubbing of the fingers. So how many of you have heard of that, that when the fingers club like that, you really want to pay attention to somebody's respiratory and or cardiovascular health when that's happened? And it means that it's been going on for a long time, and it's because due to lack of oxygen in the bloodstream. When you think about these valves, this is a healthy one, but if there's vegetation on these valves, this is obviously one that is not so healthy. So the thing about any pericarditis, epicarditis, myocarditis, endocarditis, they can be viral. So viruses can actually cause them. But when we're thinking about this acute and we're looking at bacteria, Staph aureus is a big one here, but also Streptococcus pyogenes, Streptococcus pneumoniae. These are ones we've talked about causing a lot of different things, haven't we? And even Neisseria gonorrhea. This is these are some of the bacteria that can cause this acute endocarditis. Subacute endocarditis is more common, and subacute endocarditis, even though the symptoms can be a little bit less aggressive, it can actually, because of it's just the nature of it, it can sometimes go on so long that damage is done just because you don't know about it, right? So what we usually see causing subacute endocarditis, and this is referred to as SBE, this is usually from the Streptococcal viridans group. They're called viridans strep, which are going to be these sanguinus oralis mutans. Where have we heard of Streptococcus mutans before? Cavities, right? So these are going to be streptococci that are just part of your normal flora. And for some reason, they've gotten into the bloodstream, and as they've been in the bloodstream with bacteremia, they've set up house on your in this endocardium, right? And they can set up house on these valves and really do irreparable damage. And so if somebody has any sort of risk factors that this could happen to them, then they take prophylactic antibiotics to prevent these types of infections. Prophylactic antibiotics meaning what? So if you're going to have a dental procedure done, you take a prophylactic antibiotic to prevent this, meaning that you're just you're just trying to prevent something that you know this person might have a risk of having. Is that right? Most of you answered that correctly on your test, so I hope you knew that. The idea that somebody can be brushing their teeth so hard that this is setting them up for bacteremia that could end up causing SBE is kind of sad, but anyway, I guess they can. And dental procedures, and then certainly any types of operations and that sort of thing. Septicemia, very different. This is going to be when you have actively growing microbes in the bloodstream. All right. So we had talked about all of those. About 10% of septicemia. So this is actually even a little bit higher than I would have guessed. And these are some of recent numbers. Can be caused from fungal infections. And then we understand why fungal are so much more deadly. Why are they more deadly?
they're very much harder to get rid of, and even the drugs that you're using to get rid of them are deadly or more toxic, not deadly, but more toxic to us. Is that right? If you have to take oral antifungals, they can be. All right, so any questions so far? I'm kind of moving through this, but are y'all good? I think that you can see some of the death statistics, just FYI for you guys for some of this, but we had talked about how deadly septicemia can be depending on what's causing it, but it's still not a great prognosis, even with medical intervention. So you just try to prevent that from happening. The plague. The plague has really shaped the way humans have actually populated the globe, and that's just really true. There have been quite a few in history. There have been quite a few documented occurrences of the Black Plague hitting areas where we've seen millions of deaths. And here you're seeing that this epidemic in the 6th century, 100 million people. The population since then has doubled like 4 times since then. So imagine losing 100 million people back then. That's just amazing. But anyway, there are different types of the plague that we see. We see pneumonic plague, which you all can imagine is going to be respiratory disease. There's also something called bubonic plague, which is going to actually be inflammation of lymph nodes that lead to these little buboes. I say little buboes, they're not. These buboes are huge. They can be massive, like the size of tennis balls, that create ulcerative types of abscesses. So mortality rates in this form is about 15%. The pneumonic plague, the problem with that is that it can lead to septicemia. And with septicemia, it's essentially 100% fatal without treatment. Even with treatment, it's still going to be about 50%. This was called the Black Death because of the bleeding that's occurring under the skin, causing this change in the tissues that happen. And it's caused from most of you all probably already knew, I might have passed the slide, but it's Yersinia pestis. This is a bacterium. Now that we know what causes it and we know it's a bacterium, what do we have? We have antibiotics. So Yersinia pestis is now, as long as we can get an early identification of it and can isolate this, then we have chances of treating it now. But we did say Yersinia pestis is not on your bacterial list. Okay, thank you. All right, Yersinia pestis. Thank you, and I'm glad I do have it on there because the people should know about the plague. How does it take a lot to initiate infection? Not at all, does it? And we know that fleas, rodent fleas, especially rat fleas, play a role in helping to transfer this. Fleas were the major principal agents back in the day. And anyway, looking at this might give you a little bit of nightmares, not really, but they're regurgitating infectious material into the wounds. Okay, that's fine. Anyway, it's endemic in the United States, so it's still around. And we do understand that it's still out there. Just luckily now we have antibiotics, don't we? We take a lot for granted that our ancestors could not take for granted. Tularemia. Most of you all have probably not heard of tularemia, but I just want you just the basics, and you'll see this on your Francisella tularensis is the microbe that actually causes this, and I think this is on your chart. So I just mostly want you to hear about tularemia, and I think that I had put in your little chart that this is the people most at risk for this are people who are going to be handling animals, and especially, long ago we used to see this with like people skinning rabbits and whatnot. It was highest in those kinds of populations, but it can even be in domesticated animals. People who work a lot with animals, there is an immunization that they will get. It's not really recommended or required of just the whole population, but if there's a lot of exposure to animals, especially animals that can be wild or whatnot, then they are recommended to get this. And the most of the reason why they are is that the mortality rate is fairly significant. Yes?
You said it's bacteria.
Is it not?
Mm-mm.
No.
I didn't put it on there. Okay, never mind. But if you ever heard of tularemia, would you say you heard it here first? Okay, fine. If it's not on your chart, are you going to be responsible for it? No. So thank you for letting me know that that one wasn't on there. I probably should have added it because there are people now here who actually, and I work in our, zoos and whatnot. They get this. Vets' offices, some of them, they actually get this immunization to help to prevent this. I don't think there was anything else I was going to tell you about it. And if you look, there are quite a few. I should have actually put this on your chart, but I didn't, so okay. All right, Lyme disease, and thank you all for holding me to that. Lyme disease we've all heard of, haven't we? It was named this because of where we saw our initial cases in this country was in Lyme, Pennsylvania. And probably y'all remember that too. But anyway, Lyme disease is from a bacterium known as Borrelia Burgdorferi. You've probably got that on your chart, don't you? Borrelia Burgdorferi. And this is a spirochete. This bacterium is transmitted to humans through a tick bite. And when I say bite, I'm using that loosely because actually we know it's transmitted by ticks, but we don't think you have to have had a bite for it. The tick could have just moved across you. You know what I mean? So, so people mostly just need to be cautious if they're in areas where there are a lot of ticks. They need to wear the protective clothing, maybe the sprays that can help to repel these insects, and then just be cautious. And if there is a tick, remove it, quickly and that kind of thing. What I do want you to know is associated with the initial stage of this is sometimes you get what's called a bullseye rash. Now this, you can really see why it's called a bullseye rash, can't you? This picture. And if that happens, it doesn't happen in all the cases from the bite. This erythema meaning a redness, right? Rash. Migraines, it's like there's a redness where the bite is, but then this redness moves out and there will be a clearing. So this is where the first redness was. It was tiny at first, but it migrated out and then it gets red again in the center. So really looking like a bullseye, doesn't it? If this is a rash that you have when you go in, if you have flu-like symptoms, guess what they're going to treat you for? Lyme's disease. That's exactly right. The thing about Lyme's disease, and I think everybody maybe already knows a little bit about this, it's really important to catch it early if at all possible, because that's when you can easily treat it for cure. And it's treated with an antibiotic. The problem comes in is when it's not caught in that earliest stage, and weeks and months later, it can end up causing joint problems, even neurological problems, and then it's difficult, very difficult to treat. Yes, Jared?
I heard that I think it's easiest to find through an indirect serology test.
Yes, just like most of our, and that is exactly what we want to be doing, just like most of our diagnosis, especially for things we can't grow on an agar plate, like in a 24-hour period, which we can't do with this, is going to be serology testing, either direct or indirect. And the indirect is often what we're having to do. Very good point.
Because when I was tested for it, they told me that if I tested positive for it, I would always test positive for it.
Because you're going to have the antibodies. That's exactly right. So were you having symptoms at the time?
Yes, ma'am. I actually had the bullseye.
You did have the bullseye, and you already had started your antibody titers were already coming up. So you got treated early. That's exactly what you want to have happen. And it is true, once you have antibodies, you're going to have them. So that test would always come back as positive. It's very true. Okay. So you guys can see a little bit of how this kind of goes here. And this is a area where in the United States we've seen cases of this. So you can see they're very much in the Northeast, right? But certainly in Virginia as well. And even if it's just a tiny little dot, it does mean that there are cases. So please understand that. And if you really look at the numbers, it's kind of throughout. At first, we were just seeing it in Pennsylvania, which is up here. So Pennsylvania, and then all of a sudden, it took very few years before it was like seen in many of the states. This is talking about the ELISA testing for antibodies, Jared. So it does that. So, anyway. And that bullseye rash is something that you love to see if you suspect that, because that can really help you out with that diagnosis. Because everything gives you flu-like symptoms. It's really kind of tough. But we're expected to be perfect, aren't we, and the medical community, and know everything that's going on. And by the way, let me say this to you guys, because it can be a little scary getting out there and practicing, or having even family members that have something that's sort of scaring you. Most things that are going to go on, there may never be an actual ID you can put your finger on. So just be aware of that and be not disappointed about that, because that actually happens. The good news is that we have lots of means and methods that we can rule out some of the scariest stuff. And so ruling out some of that scariest stuff is a win. Do you hear what I'm saying? Okay. Anyway, infectious mononucleosis we've talked about. We say we call it the kissing disease sometimes. And about 90% of the population actually has antibodies to this EB virus by the time we're adults. So we've already been exposed to it. But we do understand that it can cause, especially in young adults, it can really cause a prolonged type of illness that can last kind of weeks, especially in young adults. The incubation's really long, isn't it? So for this virus, it's really long. And the people who have sort of exacerbated signs and symptoms can have all of these types of things, or just a few of them being part of it. Fatigue is the main thing that you see people complaining with, is just extreme fatigue. This virus has sometimes, speaking of this extreme fatigue, this virus has been linked to, have y'all heard of fibromyalgia, which is considered an autoimmune disease? Fibromyalgia, an autoimmune disease that causes painful joints. It causes, tiredness, this chronic fatigue type situation that happens. It is thought that this might be something that is a sequelae, if you will, to this particular EB virus. So, and we know that most people have been exposed to this virus sometime in their young life. So for some people who end up developing fibromyalgia, there seems to be some indication that it might be related to our body's immune system response to this EB virus. So, okay. All right. How are y'all feeling? Do you have questions? If you have questions for me, please stop me. Okay. We're moving through this pretty quickly. That's great. Hemorrhagic, what does that mean? Hemorrhagic. If you're hemorrhaging, what are you doing? So somebody might have said that, I'm sorry. So it means like you're bleeding out, right? So hemorrhagic fever diseases. These hemorrhagic diseases that we think about, the most dangerous, these are viral illnesses. And I think everybody remembers Ebola, right? So Ebola, which we know at first was recognized and talked about in Central Africa. Since then, it has moved from that particular region and moved a little bit from there, but we still think about this in those particular regions. I would really highly recommend anybody in your spare time, nobody laughed, in your spare time, but I would highly recommend you guys to read The Hot Zone. It's by Richard Preston. It is again, it's called The Hot Zone. He is a journalist, but this book reads like a thriller. It really does read like a thriller, and it is absolutely all true. Where he talks about this disease and talks about quite a few year period there of when we were first seeing some of these outbreaks of Ebola, and it is definitely worth reading. Okay, so if you can read that, that would be great. I think you would end up liking it so much you would email me saying thanks for that recommendation. Anyway, so Ebola has a really high mortality rate. So what has to happen quickly is that the areas have to be quarantined down, and people, it's a biological hazard 4. Do y'all know what that means when we talk about 1 through 4 biological hazard? Do you? does your textbook talk about that anywhere? I don't even know if it does. So anyway, this is rankings as far as like what's the most dangerous thing to other humans. So the highest ranking is a biological hazard 4 ranking, and that means you have to be in full body gear before you can go in and handle in this particular virus because it is this deadly. Anyway, then we have yellow fever, which is endemic in Africa and South America as well. And again, mosquitoes play a role in that. Dengue fever, which Asian India. I don't know if I have these on your chart. Do I? I think I might have them mentioned. Do I have them mentioned? Good. Okay, so looking at some of these hemorrhagic fevers, I think I have a couple of these mentioned. You'd only be responsible for what's in your chart. I kind of condensed it down for you. So what would it require? It would require people having travel in their history, wouldn't it? Did y'all get that from those particular ones? That it's going to require that? Non-hemorrhagic fever diseases. So these aren't ones that you're going to be bleeding out all over the place. And by the way, those hemorrhagic ones, obviously one of the biggest worries is shock, isn't it? Because you're going to be bleeding out. So it's going to be shock that you're worrying about in cardiac arrest. And non-hemorrhagic, these are mostly bacteria that we're going to be thinking about. Brucellosis, do I have that one? I don't think I do. Do I have that one? Is that on your bacterial chart? Brucella, abortus, and sui, you don't have those? Abortus mellitus, none of these Brucella species? No? Okay, that's fine. But anyway, this is one that also can cause what's called an Underling Fever. So it's a fever that kind of comes and goes, and you know, it supposedly so it can, and animals can cause spontaneous abortions. So in some of our like cows and herds like that, you'll see this happening and spreading quickly through that. It's in the placenta, not in humans, but it can be in those particular animals. Q fever is another one. This Coxiella burnetii, I don't think I have that on there either, do I? Do I? Okay, so these are just some of the non-hemorrhagic fevers that can actually happen. And these are bacterial. The good news about bacterial is what can we do? What can we do? Yes, we can treat. This one I do have. I know I have this one on your chart. It is called, it's called Bartonella henselae, which you all call cat scratch fever. So guess who we get this from? Yes. This can be, most of us have antibodies against this. What does it mean? If we have antibodies against it, it means we've been what? It means we've had exposure. Did it cause us to be very sick? No, not at all. But in some cases, it can cause lymphadenitis, which is inflammation of the lymphatic tissue and nodes. It can cause lymph nodes to swell a lot, and usually those nodes are going to be in a direct line from wherever you got scratched. So history of having pets or that sort of thing is going to be important. Again, it's bacterial though. So because it's bacterial, there will be, you know, sometimes you can actually, you know, treat it, and 80% of the cases being in children. So disease can be prevented by making sure that anytime there is a cat scratch or there's any kind of animal injury, that it's being cleaned really well and properly, right? Rocky Mountain Spotted Fever, Rickettsia rickettsii. Y'all remember this one? Are they sounding really familiar to you? All right, so Rickettsia rickettsii. This is a spirochete, and it's a bacterium. And the good news is that if you can catch it early, then it can be treated. The bad news is that for some people who don't catch it early, this is going to interfere with cardiovascular function, including hypotension, throwing blood clots, and bleeding out. Petechial rashes are very, very common with this one, with this particular illness. So you'll see these petechial rashes on the palms and on the soles of the feet and everywhere else in between. You'll see them all over. They'll be diffuse. And again, you have to act quickly to cure this. We know that ticks are going to be involved in the transmission of this. And again, looking at ticks and where they are, I think I have a map. Maybe I don't have a map of this one in the United States, but anyway, this is really kind of all throughout the United States. Rickettsia rickettsii. Treat it though with antibiotics. So good. How to prevent it? Same way you try to prevent the Lyme disease. So this is kind of just a little chart on these non-hemorrhagic fever diseases and whatnot. Now these last few, I think I do have these in your. I think I have these protozoa on your protozoa chart. So let's see if we do. And the reason I do is especially because of Chagas disease. Chagas disease is something that would require history of travel, and that would be to Central South America. It's considered it's called the new AIDS of the Americas. It is from Trypanosoma cruzi. It's a protozoa, a long incubation rate, and it's very difficult to cure. It actually is going to multiply in muscle cells. So imagine this, it's diffuse within our muscles, these protozoa, these parasites. They end up getting into the bloodstream and then also rupturing cells as they're there. So you can have mild to severe fever, nausea, fatigue. Chagomas are going to be these where the bite actually happens from getting this particular infection, and so you can have these like huge swelling areas. So again, some of the things are, I think there is an immunization for this, but it's who's been to Central and South America recently? Anybody? No, me neither. Okay, I think if requested that there is an immunization against Chagas disease, but I'm not sure it's being required of people to get this and whatever. So prevalence, 8 million people, 300,000 of whom live in the U.S. right now. So it can cross the placenta and be transmitted vertically. So that's something to think about too. One of the things I wanted to tell you too is not just about this one, but also about Borrelia, and I think I only have this one mentioned. Do I have this one in your chart? This is the one that is in Africa, so not Central South America, but Africa, and it causes sleeping sickness. This sleeping sickness, this was described, people who have this, they're described as zombies because it goes to the central nervous system and attacks the central nervous system, literally creating zombie situations, and the mortality rate is really, really high with this one. You know, you just don't want to think about a protozoa being in your central nervous system, do you? It's bad enough with the Chagas disease being in muscles and the cardiovascular system. Okay, so let's see. And I think the last thing is anthrax. We know that anthrax is caused from Bacillus anthracis. That is a bacterium. We don't really think about it too much anymore just because of regulations and practices we have for sheep, wool, and how we treat those types of materials where animals, because this is in the soil, these endospores are in the soil, but because of regulations and our manufacturing things now, we don't really worry about it too much. But sometimes we see wolves. This can lead to what's called wool sorters disease, which we see from people like rugs that were made in other countries, and then they get brought into this country and handled. And so they sometimes have the endospores, so there's something called cutaneous anthrax, and they can leave huge necrotic regions like ulcerative lesions. The good news is that it's treatable, the cutaneous form, but the respiratory form of anthrax going into the lungs is incredibly deadly. So the things that we hear about anthrax now is more as a bioweapon, don't we? So bioterrorist and using it as a weapon to try to terrorize
First
people.
page. No, one up on the last.
Bacillus anthracis.
Mhm.
Okay. Is that good? Is everybody good? All right. And that might be, is that the last one on here? And I have a lot of slides on it, and y'all have access to these slides, don't you? Okay. All right, wait a minute. Did I have other? Is that it? How do y'all feel about that? Feel good? All right. Okay. Do you have any questions for me? On that bacteria, can we do this? Can we do this just because I want to take just 3 minutes for this? Can you all get out your blue, just the bacteria thing, right? Are there any we haven't talked about yet? There are? Which ones? Okay, so that's epidermis. The epidermis is your outer, most superficial layer of the skin, right? This is just part of your normal flora. It has really low virulence usually. It's one of those species of Staphylococcus that can cause disease, but the disease is usually not nearly as serious as like Staph aureus, because this particular species doesn't have those virulence factors like those hemolycins, right, and whatnot. So we can see Staph epidermidis sometimes causing disease, but usually it's not going to be nearly as serious of a disease. We see it sometimes with men and urinary tract infections when they, especially if they've had indwelling catheters, right? What else did I say on the chart about it? What'd you say? Oh yeah. So what else different did I say about it on there? Did I just tell you? Low. So that's all you. That's kind of. So y'all will have heard of it. There's also a saprophyticus, epidermidis and saprophyticus. Those are ones that you will sometimes hear about, but you'll know you won't be nearly as scared for your patient as if you heard which one, aureus. Okay. Not that they don't have a mortality. No, they do have a mortality rate, just not as high as the aureus. Okay, what other one in the bacteria have I not talked about? I just want you to have heard me say them, and what other?
Yeah, I don't know.
Okay, thank you so much, because see, that's what I call, thank you, Enterococcus is what, and y'all pay attention to this. Yes, Enterococcus is what I call those streptococcal viridans group, the sanguis, those, and they're really, it's some of them are Faecalis and Faecium. They're the lesser streptococci species, but collectively they're called Enterococci. And by the way, these are part of our normal flora in our colon. So these are like these are all around, aren't they? But what do we really worry about? We worry about them in wound cultures. We worry about them causing subacute bacterial endocarditis. What else do I have on the chart?
Pseudomonas cerevisiae.
Oh no, I meant about Enterococci. Did I have anything? Okay. So then Pseudomonas cepacia is a species that is in the Pseudomonas genus, like Originosa is, but Pseudomonas cepacia, and they're about to rename this. I'm not going to call it anything different though. But anyway, Pseudomonas cepacia is one of those that will be the last thing you hear about with a cystic fibrosis patient, because it's going to kill them. I think I told you all about the two little boys, brothers that had cystic fibrosis. Did I tell you all that story?
About the one who.
Two little brothers. They would come to UVA. They both had cystic fibrosis. A 1 in 4 chance that they have it, right, from their parents. They both had it. And one little brother, they both had Pseudomonas aeruginosa that caused respiratory disease. They both were battling respiratory illnesses. They both were battling all the stuff that they did. But one of them got tested positive for Pseudomonas cepacia. And the mother had to get an apartment and separate the boys. They never saw each other again, the brothers. They had to separate them.
Yeah, different story.
That's sad, isn't it? Now, not all families would have even had that ability financially to do that, but they had to do that. I have chill bumps. Are y'all hearing that? They had to separate them. It's why they try not to keep those kids in a hospital too long, because while they're in the hospital, could they be exposed to somebody who had cepacia? Yeah. That was tragic. I even know where they lived. So those two little boys. Anyway, what's another one on the bacteria that we haven't said out loud, we haven't talked about? Shigella. Shigella is got several species that end up causing dysentery. You guys, dysentery is very different from diarrhea. Diarrhea is bad enough, isn't it? Dysentery means it's bloody diarrhea. And if it's bloody diarrhea, that means that, you know, your tissues are compromised, you're bleeding from these regions, right? So, and it could be significant blood loss. So this is a very different kind of thing. Shigellosis is the illness that Shigella, the bacterium, can cause. And there's several different species, but we think about, it takes a very low infectious dose to get sick. The people can be very sick, and you know, anything that can compromise the membranes that there's bleeding is obviously something of concern. So, you know, it can cause somebody to be real sick. I had a friend who got that from the lab. It was a guy who always kept his pencil in his mouth. You know people who keep their pencils in their mouths? Well, that's okay to do unless you work in a micro lab, and then you should not do it. So you're not putting anything in your mouth. So, and he got sick because he had a patient he was working on that had Shigella, and he obviously transferred it to himself. We think it was from his pencil. We don't know that for sure, but that's what we thought. And he was in the hospital like a week. He got better. And he,
Did the test and stuff on your brother?
yeah, he was sick. So anyway, so Shigella is a, you know, gastrointestinal illness, causes severe diarrhea. That's actually not even diarrhea, it's dysentery. It can be dysentery, right? Yeah, obviously, any of these things that are going to cause lesions like that can lead to septicemia, and this is going to be, you know, very serious type of illness. Did I say anything else about it in there? How about you? How about any others?
There's 5 more.
Yeah.
Okay, well, we'll talk about those later. I just want you to have heard them. You can maybe try to remember something that was said, because on the test, so important. On this test, well, you have to know if it's bacterial, protozoal, fungal, viral. You'll have to know, right? And you'll have to know what they cause. And you're looking at them now, not waiting until next week. Okay.
When is our test?
I think I said the last day of class, which is what?
The first.
I think I said the first. So,
Is that the first or the sixth?
okay.
Yeah.
Okay.
I thought our last day of class was like